So our presentation is over heart failure. This presentation is by Tori Bailey, Megan Barnes, Christina Bozarth, Gracie Harvey, Alex Woodard, and Caitlin Zellhart. So some background information on the pathophysiology. Heart failure is a chronic progressive condition. The heart attempts to make up for the inability to adequately pump blood by enlarging, increasing in muscle mass, pumping faster, narrowing the blood vessels of the heart, and diverting the blood away from other tissues, and making the blood go towards the brain and the heart. So there are different types of heart failure. There is left ventricular heart failure, and with this you can have systolic left ventricular heart failure. This would mean that there's improper contraction of the heart, resulting in a reduced cardiac output and ejection fraction. There's also diastolic left ventricular heart failure, which is improper relaxation, resulting in a reduced cardiac output, and this has normal ejection fraction, which makes it different than the systolic one. And then you can also have combination of systolic and diastolic left ventricular heart failure. And then there's also a right-sided heart failure, and this may be due to a left-sided heart failure or having some type of lung disease, and this is called cor pulmonale, like we've talked about in class.
As a quick recap of epidemiology, epidemiology is made up of incidence and prevalence. And prevalence is going to represent the number of people in a certain area who currently have the disease. Incidence is going to represent the number of people being diagnosed with the disease every year. So if we were to use the analogy of a bathtub, a faucet with water coming out of it is a lot like incidence. So that's number of people being diagnosed every year, and that's being poured into the bathtub. And the water in the bathtub represents the prevalence, or the people who are currently living with that condition. The only way to decrease the prevalence is for people to either be healed or or through death. So that's how water gets out of the bathtub. For heart failure, the prevalence in the United States is 5.7 million people, which is quite significant. And then incidence is over 0.5 million people per year, so 500,000 people, and that's the water being poured into the tub. So unfortunately, prevalence is increasing with time. So by 2030, there are projected to be 8 million people with heart failure in the United States, and that is a 46% increase in the prevalence. So the water in that bathtub is going up by 46%. This graph just represents that in graph form. So the solid line with the triangles shows where heart failure was projected to be by 2040, and the dotted line with the squares shows where heart failure actually is. So this is the incidence rates right now. So in 2007, you can see that heart failure incidence was projected to be at about 400,000 per year, and instead it was actually 670,000 per year. So by the time we get to 2040, according to this projected graph, it was supposed to be 770,000, and now you can't even see where the graph cuts off at that point because of how much it has skyrocketed.
Medical management for heart failure includes angiotensin converting enzymes, or ACE inhibitors, angiotensin II receptor blockers, beta blockers, diuretics, aldosterone antagonists, inotropes, digoxin. We will discuss these further in the following slides. Angiotensin converting enzyme inhibitors are a type of vasodilator, a drug that widens blood vessels to lower blood pressure and improve blood flow and decrease the workload on the heart. Angiotensin II receptor blockers may be an alternative for people who can't tolerate ACE inhibitors. Beta blockers are a class of drug that not only slows your heart rate and reduces blood pressure, but also limits or reverses some of the damages to your heart if you have systolic heart failure. Diuretics will make you urinate more frequently and help keep the fluid from collecting in your body. Aldosterone antagonists are potassium-sparing diuretics. Inotropes improve heart pumping function and help to maintain blood pressure. Digoxin increases the strength of your heart muscle contractions.
Okay, so in addition to medical management through medication, you also have surgical procedures. So one is coronary bypass surgery, or using a graft, so as we know as CABG. This is where they take blood vessels from your leg, arm, or chest, and then bypass a blocked artery in your heart to allow blood to flow through your heart more freely. They also have heart valve repair or replacement. So repairing or replacing a faulty heart valve. The surgeon can modify the original valve to eliminate backward blood flow. Surgeons can also repair the valve by reconnecting the valve leaflets or by removing excess valve tissue so that the leaflets can close tightly. So they have either one, whatever is more appropriate. Another one is the implantable cardioverter defibrillator, or the ICD. These are implanted under the skin in your chest with wires leading through your veins and into your heart. The ICD then monitors your heart rate and tries to pace your heart or shock it back into normal rhythm if it becomes too close to that assigned thing. This is what we talked about, how when we're exercising, we want to stay at least 10 away from that, or even 20 to be really safe. Some other surgical procedures, we have the cardiac resynchronization therapy, or biventricular pacing. A biventricular pacemaker sends timed electrical impulses to the chambers so that they pump in a more efficient, coordinated manner. You also have the ventricular assistive device. This is a mechanical pump that helps pump blood from the chambers to the rest of your body. So the implanted heart pumps can enhance the quality of life for people who aren't eligible or able to undergo a heart transplantation or are waiting for a new heart. So that's an option for many people in that situation. And then of course you also have the heart transplant, but as we know that's kind of rare because you have to fit certain criteria, and then it's hard to meet those and actually have a heart available for you. So that's more rare.
The next few slides just include an overview of the American College of Sports Medicine guidelines for exercise for patients with heart failure. For aerobic guidelines, the frequency should be 3 to 5 days a week, using either heart rate reserve or RPE as a gauge for intensity. If you have max exercise testing data, you should exercise them at 60 to 80% of their heart rate reserve. If you do not, or if they have atrial fibrillation, they should be reporting between 11 and 14 RPE. For time, you want to progressively increase to 30 minutes and then up to 60 minutes as the patient tolerates. Modes of aerobic training include walking and stationary cycling. For resistance training of these individuals, you want to do 1 to 2 days a week, non-consecutive days, so you want to make sure there's at least a day in between. The intensity for the upper extremity should be 40% of their 1 rep max, which is just slightly lower than the 50% 1 rep max for lower extremity. You can gradually increase them to 70% of their 1 rep max. You should do 2 sets of 10 to 15 reps for each exercise. Machines are preferred because this is better for low strength and balance. The guidelines for flexibility include that stretching should be done greater than 2 to 3 days a week, with daily being the most effective. You should stretch until the point of feeling tightness or a slight discomfort, holding each stretch for 10 to 30 seconds for static stretching, and doing 2 to 4 reps for each stretch completed. The different modes of flexibility are static, dynamic, and PNF stretching. At this point, you can pause the slideshow. This is just a helpful table that puts all of this information on one slide. Exercise training considerations for patients with heart failure can be seen on this slide. These include general principles such as intensity of 90% of heart rate reserve may be indicated for select patients only. You should progress slowly with exercise volume, and you should increase duration and frequency before you increase intensity. And resistance training actions can be added after the patient has adjusted to and is able to tolerate the aerobic training.
These are some exercise guidelines that we found that weren't ACSM. ACSM is obviously in our profession gold standard, but I just found these on the internet and just thought I would add them in from the Heart Failure Society of America. Just do 30 minutes of exercise a day on most days. Make sure warm up and cool down are essential. Those are essential in most disease processes. And then avoid extreme temperatures, hot or cold, and then always be aware of the signs and symptoms of overexertion. Make sure your patient is educated on where to go if they experience any of these signs and symptoms, and just what to do if they were to happen. The first study that we found was stationary biking with CHF patients. The objective of the study was to determine the effect of exercise training, specifically stationary biking, in patients with chronic heart failure. They performed 40 minutes of it 4 times a week for 8 weeks. There was one group that did this and then one that was just sedentary. The outcomes were that the training increased lots of values such as lung diffusion, peak oxygen uptake, and anaerobic threshold in the exercise group. The results for the exercise group were significant compared to baseline values and the control group. The applicability of this study just shows that moderate exercise training can definitely be part of our plan of care for patients with chronic heart failure. And then I would say that a drawback of the study was that both of the groups it was all men. I think that, just biological differences in the sexes, it would be nice to see how these interventions affected women, and then also a longer study. I think the N was 38, so just a larger number of participants, just to see and make sure that the outcomes were not by chance or anything. The second thing that we found was the Cochrane review. The objective was to determine how effective exercise-based rehab is on mortality, hospitalization, morbidity, and health-related quality of life for people with CHF. The outcomes were that exercise-based rehab reduced the risk of hospital readmission, it improved the quality of life, and reduces mortality in the long term regardless of other factors such as age, gender, and severity of the disease. Again, applicability, just, we're confident that exercise training will improve quality of life and won't cause like a regression in the disease process, that it all, has positive effects. And then a drawback for this study was that more research always needs to be done, but, specifically more research needs to be done to show the benefit of the exercise in the heart failure patients with preserved ejection fraction, and then also about exercise in the home setting. So these are just our credits. We all worked pretty well as a group, as usual. So these are just the things that we did each, and then we all worked on it. And then here is our references. Thank you.